Next up, we have Dr. Neil Clancy. He's an associate professor of medicine at the University of Pittsburgh.
Well, great, thank you. I raced up here because I may have been over-optimistic about what I'll be able to get through, but we'll give it a go. I'm also chief of infectious disease at the VA Pittsburgh. So I'm going to offer a human perspective, and let's start with a case. So this is a 65-year-old woman who gets a lung transplant, and she's admitted to the hospital with pneumonia. So our standard treatment in someone like this, the biggest, broadest spectrum antibiotics we have are the carbapenem class, and she gets started. 3 days later, however, we discover that she has a Klebsiella infection that's resistant to carbapenems. So there's a new carbapenem-resistant pathogen antibiotic approved by FDA called ceftazidime avibactam. She gets started on that. For 2 weeks, she does well, the drug gets stopped, and she relapses. At this point, we recover 2 different Klebsiellas that are highly drug-resistant, but they're not carbapenem-resistant. She gets treated with another course of ceftazidime avibactam, appears to do well, but then the same scenario happens. After stopping the drug, she relapses. And at this point now, we've got yet a 4th type of Klebsiella that's been isolated. She gets put back on the carbapenem since this did not test as carbapenem-resistant, but really doesn't respond at all at this point. And then she gets other pathogens that show up, including, again, now the carbapenem-resistant Klebsiella. Different antibiotics get added on, but after 50-something days, she dies of her infection. So this is a case of CRE, or carbapenem-resistant Enterobacteriaceae. Klebsiella is one of the Enterobacteriaceae. And these are the so-called superbugs that you're reading about in the early teens, and they got widespread media play. So why? Are they really a big deal? Why were they all over the media? And the reason is that over the course of the aughts, these exploded throughout the United States. And if you look at the map in the upper right-hand corner, Pittsburgh and the Northeast were really ground zero for the emergence of these CREs. And since the emergence in the Northeast United States, they've now spread globally. And if you look at the bottom right global map, the darker the color, the higher incidence. If you look at India, Southeast Asia, you have countries where over 50% of Enterobacteriaceae are resistant to carbapenems. And I'll also point out the gray areas are not areas where there's no disease. That's the vast bulk of the world where we're not even doing surveillance and we just don't know. So the other impact of these, and we don't get all our medical information from the Daily Mirror, but in fact, the Daily Mirror is right. The UK government, bears welcome, estimate that by 2050, without a change in what we're doing, there'll be 10 million deaths a year due to resistant pathogens. So the other impact of this is not only patient outcomes, but it's economic, right? So if we look at the latter half of our patient's stay, from the time at which she failed the course of treatment with the ceftazidime avibactam for a second time, that cost $750,000 in hospital charges. So this is the worst of all possible outcomes. You burn money and the patient has a bad outcome. The other economic impact is that you lose productivity from people. So the estimates are between now and 2050, again, $100 trillion will be lost in economic activity due to drug-resistant pathogens. So the World Health Organization, CDC, other governmental bodies throughout the world have defined levels of antibiotic resistance threats. And urgent threats really include our friend CRE, carbapenem-resistant Enterobacteriaceae. Other infections you might be familiar with, C. difficile, a common cause of hospital-associated, antibiotic-associated diarrhea. And then ominously, gonorrhea, or gonococcus, which causes gonorrhea. So this is not a hospital disease, this is a community disease that is an urgent threat resistant pathogen. So if you go through serious threats and concerning threats, you've got a combination of things that are found in sick patients within the hospital, but you've got other things that are found broadly in the community. MRSA, resistant streptococcus pneumoniae that causes community-acquired pneumonia. So we've known from the beginning of the antibiotic age that resistance comes hand in glove with antibiotic use. And in fact, Fleming himself, upon the introduction of penicillin to the market, noted that irresponsible use of these agents morally makes you responsible for the death of people due to the emergence of resistance. And resistance is inevitable. So heeding that advice, the medical community for 6 decades largely did nothing. And in fact, here's a paper from 2007 from the Infectious Disease Society of America surveying hospitals for antimicrobial use. And what they found is that, in fact, practices to improve antimicrobial use are generally inadequate and not routinely implemented in U.S. hospitals. So why was IDSA looking at this in 2007? And the reason is that in the early aughts, just as here on the bottom right with the black bars, you can see the emergence of highly resistant pathogens such as CRE, all of a sudden the field realized there are no drugs in development. So to the left there in the gray are FDA-approved antibiotics reaching market. And you can see in 5-year intervals the decrement. And moreover, because it takes 10 to 15 years to get to market, this had been going on for a decade without the community really doing anything about it. So that brings us to the era we're in now, where we've actually got mandates then for antimicrobial stewardship. In order to get hospital accreditation, in order to get paid by Medicare and Medicaid, you've got to have programs in place that show you've got stewardship on the ground in your hospital. And CDC has published core elements for programs to start implementing stewardship in the hospital, in nursing homes, and in outpatient settings. So right now, about 60 to 70% of U.S. hospitals have a formal stewardship program. The goal is to get to 100% by 2020, but it's going to be a heavy lift. So CDC defines 7 core elements of effective stewardship, and they involve multiple parts of sort of the healthcare team, right? Beginning with institutional commitment, leadership commitment, human resources, material resources, IT resources. There has to be accountability, expertise, action plans, and then most importantly, tracking and measuring metrics in response to those action plans. And with that, understanding what you have, reporting it, and educating both professionals and the broader community. And this involves then multiple partners. So on the bottom left there, you see physicians. And it's sort of astounding that put this together with physicians is that we're not the circle at the center. And in fact, we've got clinical micro, we've got pharmacy, we've got nursing, we've got institutional leadership, and crucially, we've got infection control and hospital epidemiology. And there's no single template. Every hospital has to come up with its own plan because every hospital is different. UPMC Presbyterian is different than Children's, different than Mercy's, and altogether different than, say, like a place like Bedford out in the rural part of the state. So do these work? So this is a study from 2011, one of the first to summarize the literature up to that point. And at that point, there were 38 studies looking at 6 different intervention types. And what they found is, yes, it works. You can reduce drug use, you can lower costs, you can shorten duration of drug treatment, you can reduce inappropriate use, you can reduce toxicity. There are no adverse events on patient outcomes or toxicity or lengths of stay. And moreover, if you keep an intervention in place for 6 months, you'll begin to see decreases in resistance rates. So let's talk about some of the stuff in Pittsburgh that we've done. So up at the VA, the program's run by my colleague, Brooke Decker. She's focused on the outpatient setting. So up top there, you can see a baseline period, a period where we did a peer review, an educational intervention, and then a period a year later after the original intervention. So as you move left to right in the top graph, you can see total antibiotic prescriptions in outpatient clinics at VA Pittsburgh dramatically decreased. So the pie charts at the bottom focus on the red and green parts of the chart. So the red part of the chart is inappropriate antimicrobial use, where you're giving an antibiotic when there was no reason to do it. And this is consistent with what's been shown in every study. In the United States, 50 to 75% of antibiotic use has no medical indication. And that's where we were at the baseline period. And if you notice, we've made progress. We've reduced that by about 20% moving across the intervention and post-intervention period. And hand in glove with that, we've doubled our appropriate use, our optimal use, as shown in the green part of the pie charts. So that's good news. The bad news is that we've still got about half of our use is not indicated. So we've made progress, but we still have a long way to go. UPMC was one of the first stewardship programs in the country, 2002. That's run by my colleague, Hong Win. And what they've shown at UPMC is when you put a stewardship program in place up top with those arrows, you can decrease the use of target antibiotics. And I don't have it on the graphs on the bottom, but resistance rates to those antibiotics also dropped within months of putting the program in place. And the good news on the bottom, if you look at the 4 big classes of antibiotics that we have, we've maintained flat resistance rates. So you can sustain the gains you've made with resistance. But of course, the bad news here is if you look at those resistance rates, they're on the order of 5 to 30% for the four biggest classes of antibiotics we have, among, in this case, gram-negative bacteria, E. coli and Klebsiella. So that brings me to One Health. And in honor of St. Patrick's Day, I've shown the famous One Health shamrock there. But Allison did a great job, and also Patricia with the Rachel Carson reference, showing how this is really all interconnected. And Allison had her own figure similar to mine here on the bottom left, showing this interconnectivity. But for our purposes, in the middle there, of course, is food. And there are two modes of antimicrobial resistance emergence. One on the far left there is from antimicrobial use, and then the other is transmission of resistance between environment, patients, animals, etc. So the Academy of Medicine has pointed out that the vast majority of use is in non-human sectors. So if you're going to be serious about getting at resistance, you've got to go with the 80% of use that is non-human. And otherwise, we're not seriously addressing the issue. So let's go through some One Health case studies. So this is case study number 1, which was Colistin resistance. So you may remember, beginning at the end of 2015, there was a spate of articles about the end of the antimicrobial era. What was that about? And it was about this study from China that was published in November 2015, talking about Colistin's resistance in humans and animals in China. So what was this story about? So Colistin, given cases like I presented to begin with, where your frontline antibiotics have resistance and no role, Colistin had been consigned to the dustbin of history because it's so toxic. But with the emergence of these pan-resistant pathogens, it was resurrected, and it became the agent of absolute last choice for Klebsiella, E. coli, etc. Well, actually, it turns out Colistin and the broader class of polymyxins are widely used in animals throughout the world in many countries, and they're given both as treatment and prophylaxis for diarrhea, but also as a simple growth promoter, where they have no real therapeutic indication. And this use is mammoth. So to give you an idea, that's 12 million kilograms per year used in animals in China. When Allison talks about a nanogram is 1/1,000,000th of a milligram. So this is prodigious use. Moreover, it's difficult, particularly in resource poor areas, to do phenotypic testing for Colistin resistance. And since people weren't using it in humans, no one really cared. So there's no testing going on. So what this group in China did is they went to farms, they went to meat processing areas, markets, and hospitals in China, and they looked for Colistin resistance. And they found a ton of it. And what they found is that it was mediated by a gene that previously hadn't been described, MCR1. And if they went to pigs in market or at slaughter, they were finding this gene in 25% of E. coli that they were sampling. And moreover, they were finding it in about 1% of human samples. And the truly terrifying part of the story is that this was carried on what's called a plasmid. So plasmids are mobile genetic elements, which means that if I've got 1,000 bacteria, that plasmid can hop from every single bacteria into the entire population. So it's not one bug that I transmit the bug with resistance. Now I have a potential to just amplify this 1,000-fold within a community. So this is the recipe for disaster. And in fact, it was entirely predictable how it played out. Here's our media reports and the first article. Within 3 months, MCR1 is in 19 countries. And moreover, because carbapenem resistance is carried on a plasmid, it rapidly became that you had both carbapenem resistance and Colistin resistance now on the same plasmid. It was within the US in a couple months, 2 cases by June of the following year. And now there are 6 MCR-like genes that have emerged instead of just the 1. All right, just real quickly then at the end, a second study, azole-resistant Aspergillus. This is a fungus. It's found in compost and decaying vegetative matter. And it makes aerosolized spores. We breathe several hundred of these a day. They lodge in the lung, but if you're immunocompetent, you don't develop any problems. If you're immunosuppressed, however, it can kill you. 20% of bone marrow transplant recipients will develop this. So we give them drugs called azoles to prevent these infections. But azoles are also used widely in crop protection, wood preservation, and to protect fruits and vegetables. And in fact, The resistance mechanisms for pesticide use are the same mechanisms that we see with medicinal azoles. So what's happened initially in Europe, but now all over the world, is that we've seen a leap from pesticide use, where a particular mutation that I've listed there at L96H has now leapt into humans. So if we treat humans with azoles, as shown on the far right, we actually select for these resistant populations. So 25% of clinical isolates are now resistant in the Netherlands, 2 to 6% in the United States. The critical threshold for changing your practice and escalating therapy, we always teach, is about 15%. So this is profoundly altering bone marrow transplant practice throughout Europe and the US. So finally, in the last minute, is there anything we could do from a One Health perspective? And I think this is a Canadian experience that offers some hosts. They were giving a third-generation cephalosporin called ceftiofur to eggs or to day-old hatchlings to prevent infections. And what they found is that they had, in the animals, emergence of high rates of ceftiofur-resistant salmonella. But actually, this gives cross-resistance to the drug we use in humans, which is ceftriaxone. So in fact, you had ceftriaxone-resistant, frontline-resistant salmonella infections in Canada. There was a voluntary then discontinuation of the agricultural process. And what you can see in the line there to the left is after the voluntary discontinuation, you had reductions in both animal and human resistant cases of salmonella and E. coli. So it is possible to make an intervention. They've shown similar effects with banning this particular use of ceftiofur in Japan, for example. So finally, our strategies. The first step is we've got to decide what are our essential human antibiotics, and those are the ones we need to restrict in animals and in agriculture. We need to align our medical, animal, and agricultural practices. We need regulation. We need surveillance and research. But we also need things like sanitation, hygiene, basic infection prevention. We need new therapeutics, but I think crucially we need communication, education, and training. And this means bringing different cultures together. And it's quite interesting. If you talk to physicians and veterinarians, we talk about things like limiting resistance and the moral responsibility we have with that. If you talk to people in industry, they have a responsibility to employers, employees, to the community, and that's what they focus on. So we've got to bring these together. And I would say that finally, in human medicine, we can point to India, we can point to China, but we have to get our own house in order. And with that, I'll stop and entertain questions as part of the group. Thank you.